All right. Hello, everyone. My name is Rachel Stern. My pronouns are she, her, and I am a nurse practitioner. Today, I'm going to be talking about intersectionality in the context of healthcare. And, when we think about intersectionality amongst the communities that are represented here today, we can't ignore the disparities and the systems issues that do exist in our current healthcare system. So just a quick review. So intersectionality, just as it is defined in the Oxford Dictionary, it is defined as the interconnected nature of social categorization such as race, class, and gender, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. And it is a theoretical approach based on such a premise. And then when we look at health disparities, so the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So I'm going to be speaking to a few of these disparities that many trans and Black and Indigenous people of color and femme-identifying individuals face in today's society. Again, only a few because there are many that we just don't have the opportunity to cover, that we don't have the time to cover today. And I'll also be focusing more on my own practice and what I see amongst my practice. So just some background, I am a family nurse practitioner by trade. However, I am focused mostly on reproductive and sexual health and gender affirming care. So I work at Planned Parenthood of the Pacific Southwest, which is an affiliate that's based out of San Diego, and we serve San Diego counties, Riverside counties, and Imperial counties. My role there is a regional lead or regional support clinician, and then I also direct their gender affirming hormone therapy program. So again, much of what I'll talk about today will be related to sexual and reproductive health. I'll talk particularly about cervical cancer screening and breast cancer screening, but there are many, screening recommendations and many disparities that certain marginalized communities face when it comes to these screening recommendations across healthcare. So one thing that we can do as individuals is stay up to date on these regular health screening recommendations. So in my practice, that would be one of the common tests is the cervical cancer screening test. So pap smears or HPV tests. It's very common. Many people have heard of these tests. They're often recommended by your own primary care providers. But the studies show that transmasculine individuals that have a cervix, they're much less likely to receive cervical cancer screening. So one study demonstrates that 37% of trans patients had never had cervical cancer screening versus only 10% of cis women. And then 65% of trans youth had never received the HPV vaccine. And this is a very common vaccine, and youth start to hear about this at age 11 or 12. And then in my own affiliate, our data indicated that our Black and African American patients were much less likely to return for follow-up care within 3 months after an abnormal pap smear. So, what could be the reason? This is a sensitive visit, and it can be uncomfortable. It can be scary. And I think we really do need to focus on adapting patient care and patient interventions for specific populations. And we also have to look at access. How can we increase access to these marginalized communities? How can we make providers more aware of the lack of screening for members of these communities? That leads me into another very common screening practice. It's for breast cancer. So breast cancer, it can be preventable. It can be detected early with appropriate screenings or appropriate exams. But unfortunately, right now, there are a lot of conflicting recommendations for when to start breast cancer screening. That's particularly mammograms. So some recommendations say start mammograms at age 40, but now the U.S. Preventive Services Task Force says to start at age 50. And this is very confusing to patients. And the lack of consistency really could result in delayed diagnosis and delayed care. And we know that some people have a family history, and that puts them at much higher risk for things like breast and ovarian cancer. The NIH reports that Black women are typically diagnosed with breast cancer at a younger age. They're often diagnosed with more aggressive forms of cancer, and they're more likely to die from breast cancer. And they attribute these facts to biological predispositions, which might indicate that we should start screening earlier, and also environmental factors such as, of course, access to healthcare, income, other socioeconomic factors, and diet. And then when you look at recommendations for breast cancer screening in the trans population, there really aren't any. There are no specific guidelines. The consensus is very mixed. It can really be confusing for patients and for providers. So if the providers are confused, of course, the patients are going to be confused. And then again, this can really lead to delayed diagnosis and healthcare for patients who are at higher risk for breast cancer. I also did want to highlight the lack of appropriate mental health care for members of these communities. Many studies support the fact that there is limited knowledge amongst mental health professionals as far as experience in working with members of vulnerable populations, working with members of, who are Black or Black trans people. But the research also shows that members of these communities are known to be more vulnerable to violence. So trans people are much more likely to be diagnosed with things like depression, anxiety, PTSD. Black trans women are very prone or more vulnerable to violence and sexual violence. And then you think about minority stress, which would be members members of communities who have, who fall into a few of these identities, and then that really does increase the occurrence for psychological stress. Evidence also supports that research for trans people, it should include discussion of race, culture, etc. So really just that lack of knowledge and lack of awareness can result in lack of care and, of course, increased risk, again, of depression, anxiety, and even suicide. So what can we do? As individuals, really, you can be your best healthcare advocate. Advocate for yourself, find a provider who you trust, consider alternate methods of care. Right now, there's a lot of telehealth, so you can consider remote care for access, home-based testing, make sure that you're asking questions to your providers. And then as providers, I think that we can really encourage health training companies, healthcare training programs and medical research to be more inclusive, that focuses on health equity and justice, and really looks at ensuring that healthcare providers do have experience dealing with members of many different populations. And then companies can really ensure that the benefits they offer include comprehensive healthcare coverage that covers individuals of all races and all genders. I really thank you all for this opportunity, and please enjoy the rest of the summit.
Hello, everyone. My name is Ladarian Diaz, and I'd like to thank our expert for speaking. Now that we've heard from the expert, I would like to actually read some passages from members of our various ERGs, mainly our African Ancestry Network and our Women's Network. One, in answering, have allyship or advocacy helped you at any point in your healthcare journey? One member said, I didn't really have an advocate, although I did have a lot of people encouraging me to go to Planned Parenthood or to a provider in Chicago instead of a doctor I went to. The original recommendation came from my first therapist, who also sucked, and once told me she found non-passing, clocky trans women disgusting. My next therapist my next therapist, who is one of two trans therapists and the only trans woman therapist in Champaign County, who's so overbooked that I fell off her schedule and I had to see a cishet woman at her practice for a few months before I moved, told me to find a new doctor. But for some reason, I never did until I moved to Chicago 7 months ago. Another member said, yes, I feel that seeking out Black women, nurses, doctors, Allow me to feel more comfortable expressing my concerns or seeking treatment without fear of not being taken seriously or disregarded because they can better advocate for my treatment or understand the issue I may be facing. Another member, in response to have fears related to implicit bias or discrimination prevented you from seeking health care in the past, simply answered, yes. Gynecologists are judgmental a lot of times. Another member's response, yes, very much so. These fears are still very present. One of my first experiences of known implicit bias and discrimination that I was aware of happened after I was involved in a horrible car accident. I suffered multiple injuries, including a TBI and multiple broken bones. I didn't have anyone that could advocate for me at the time. My husband was in a way worse shape than I was and was treated very unfairly. 2 days before my accident, I had just started a new position at Intuit as a tax support expert. The last conversation I remember having with my husband, literally seconds before we hit a semi-truck at over 90 miles per hour, was about that job. I was proud of myself because I finally made it to Intuit. I finally reached my goal. I was happy. The day I was discharged from the hospital after 28 days, I lost my second job at the time, so it was a blessing for me to be able to come back to Intuit after I got home. I worked from my wheelchair for most of the entire season. It was painful, but I was grateful to have a job and to be alive. Hurt or not, I needed that job. During the follow-up visit shortly after I was discharged, I was told that the pain I was suffering wasn't real, even though my injuries weren't fully healed. I kind of had a feeling that this doctor was discriminating against me because she had a habit of saying little backhanded comments to me during visits. So I was already scared to speak up and ask for refills out of fear that I would be viewed as a drug seeker. When I finally mustered the courage to ask, you guessed it, I was treated like I was drug seeking. The same doctor refused to fill out my short-term disability requests, so I really needed to work during this time. I just wanted to be able to work without being in extreme pain for my entire shift. During this visit, I got tired of the doctor denying my pain and treating me like I was insignificant. I ended up breaking down in the office and had a panic attack. I was mad at myself for doing this because I didn't want to look like the angry or crazy black woman. But I was so tired of being treated that way. The black receptionist who swooped in to help calm me down and save me from being sent somewhere I didn't want to be sent told me that the doctor had multiple complaints for treating black women unfairly. So my assumptions weren't wrong. This was at the beginning of 2020. So I still don't trust the healthcare system now. I stopped getting follow-up care for my injuries because of the incident. I don't have a primary doctor now, so I only go to urgent care clinics. It has to be something really wrong for me to even go to urgent care. I really, really hate to say this, but I don't trust white doctors with my health. I didn't even want to write that because I feel horrible saying that, but it's the truth. It hurt even more because the doctor was a woman like myself. I switched to the doctor because I was initially being treated by a male doctor and preferred women doctors. I don't feel comfortable seeing male doctors for some other reasons. It's very hard to find doctors that I trust with my health now, especially in my area. I feel ashamed about that because I know I am neglecting my health. I have an extreme distrust for doctors now. Really quickly, I want to share one positive from this is one person responded, no, I have always been outspoken and do not stand for bias or discrimination of any kind. And I will call people out on it as kindly as I'm able to do so, so they learn their behavior in hurting people. I received bias and discrimination in my family growing up. I did not accept it from them, and I will not tolerate it from other humans. Birds don't like other birds for the color of their feathers. When will humans develop bird brains? So after I've read those, I would actually like to have two people join me on stage here. My two panelists today from the African Ancestry Network is our executive sponsor, Erica Terry Derrick, and the Women's Network Global Leader, Angie Robert. I'll be sitting here and
like Oprah.
I know, right?
No, I feel all fancy up here. But I want to thank you both for joining me today. And so Erica and Angie, would you please tell us a little bit about yourselves before we dive in?
Sure, I'll start. So I'm Erica Terry Derrick. All the R's and Y's. And I've been at Intuit for just over a year and a half. And I'm excited to be here today, both as executive sponsor for IAN, but also as a Black, straight, cis woman who really believes firmly that we have to tackle this intersectionality question, right? I don't get to leave parts of my identity behind as I'm walking through the world. And so I think it is really important to be in this conversation today.
Yeah, hi everybody. I'm Angie Robert. I am, my pronouns are she, her. I am the global co-chair for the Intuit Women's Network, and I've been at Intuit for about 8.5 years now. So I've been in this global chair role for just under a year, and it's truly a great privilege. And you know, we have taken on a lot of discussions about women and their bodies, and different parts of you know, a woman's body, broken down from everything from, you know, menstrual cycles to menopause to hair and all the things that we just haven't talked about in the past. Really not talked about at work, but a lot of times just aren't talked about in the world. And so I'm super happy to be here to get to continue the conversation.
Thank you so very much. And so what I would like to start off by doing is, Erica, would you be willing to share, you had some stories you want to share about loved ones and their experiences with treatment and you yourself?
Yeah, all of the stories that you read, Dee, were so resonant for me. A few years ago, my younger sister, who's wasn't yet 40 years old, had a massive heart attack, and no one could figure out what had happened. And it became this situation for our family where, you know, we obviously rallied around her, but the treatment that we received was so shocking to me, right? You're already in a moment of crisis and you're super worried about your loved one, and so you're not thinking straight. And so to have the added burden of having to advocate not just for the health care that your family member is getting, but also trying to just navigate people's biases, right? So because these doctors couldn't figure out what had happened to my very young, very able-bodied sister, they were like, oh, well, she must have been on drugs, right? And this is, you know, what caused it. And there were all of these decisions being made about her care on the basis of this assumption that wasn't true, right? So while I'm trying to understand, like, what is, you know, the terminology and how does all this stuff work, and out of my own swim lane, I'm also having to deal with the fact that, like, I have to now advocate and be this voice in the room for something that I know isn't true of my sister's situation. And it took us literally getting my own sister-in-law, who's got fancy degrees and doctor behind her title, involved in order for us to be taken seriously, in order for us to be heard. And I thought to myself, if I'm me in the situation that I'm in, with the resources that I have, with the education that I have, with the connections that I have, and I'm still having to deal with this, what must it be like for someone who has none of that? Right? What must it have been like for all those families during COVID who couldn't be there to advocate for their loved ones, right? Like, what must it be like in all of these situations where you find that Black and brown people in particular are disadvantaged, right? And then you layer on all the other parts of our identities that also chip away at the respect that we get in the world. And it's really heartbreaking and a matter of life and death. Right? So it's not just about how do I feel. Literally, you were making decisions about her health and what was going to happen to her based on a set of assumptions that were not true. So to me, these conversations are more than just nice to haves, right? They're must haves.
Right. And you speak about your sister being assumed, you know, because here she is, Black woman, assuming, oh, it's obviously drugs. You know, that parallels experiences I've had in the healthcare system prior to transitioning was, you know, I am a disabled person. I suffer from mental disabilities as well as, you know, some physical, but I was going through a very hard time with my mental disability. And when I sought doctors for assistance, they kind of made those same assumptions as, oh, you just want drugs. I had doctors tell me, oh, it's all in your head. You just want drugs. It got so bad to a point where I'm grateful that didn't happen, but I got close to being, unaliving myself because of everything I was going through without a doctor believing in me. So it was such a common thing to happen where I sought doctor after doctor, and I was not good at advocating for myself. I was very young, so I took everything they said at the value they had. now more recently, with my spouse and everything, who really has taught me a lot about advocacy and advocating for myself. The difference for me now going through transition is actually finding doctors that listen to me. When it comes to my health, going through transition and getting on I had a doctor who was like, hey, you're a little overweight. We want to make sure that, we're not concerned so much about that, but going on estrogen, there's some concerns we might have, so let's get that addressed. And one of the things the doctor said is, how do you want to proceed? And I said, well, I gained a lot of this weight during the pandemic, during the stresses, Trayvon Martin happening. That's obviously a stressor. All these intersectionalities coming together is Trayvon Martin, then everything that's happening with trans rights and so forth. All that stuff was beating down on top of me. And I said, I would really just love to get my transition started. And I'm pretty sure if I can get in a better mood, I could start to manage my weight better. And the difference from night and day between the doctors I had before and this doctor, who was like, okay, let's focus on your mental well-being first. Like, let's focus on how you're feeling about yourself. And then we'll see, in a week or two or a month or so, what to do with the weight part. And like, that's a big difference, right? That's having that person who will listen to you in that way. And I'm sorry that your sister had to go through so much, but I'm grateful she had you in that situation. So Angie, and in our conversations, one of the things you talked about was kind of where you stand and things. Can you tell me more about, kind of your journey with healthcare and where you're coming from in all of this?
Yeah, definitely. So I, want to acknowledge right out the gates, I've had very different experiences in the healthcare system. But I truly believe that my role playing here is to advocate on behalf of all women and anyone who identifies as a woman. And so, I think we just have to continue to have these discussions, knowing that the healthcare system is inequitable, right? It was built by men, right? They didn't include women in research studies because their menstrual cycles or their giving birth got in the way. And so there are decades of data that don't even address women's needs, women's health, nothing. So, it's important that we, continue to, push for removing gender biases in the in research, in the medical field, et cetera. As I thought about how I might answer this question, I thought about really two scenarios or two learnings that I had that I think, we can all learn from, regardless of, who we are in the world. When I was 26 years old, I was diagnosed with thyroid cancer. And it actually came from, on the heels of a long bout of anxiety and depression and a lot of mental challenges that I was going through. And honestly, a cancer diagnosis just felt like, a kick in the gut at that point, right? But, I was young, and maybe we still feel that way. I don't as much anymore, but when you heard the C word, you were like, well, I'm gonna die. And I was also raised in a family that was like, respect authority, don't question authority, right? If someone has a degree, which fewer people in my family had degrees than did, like they were smarter, they knew the answers, right? So I was diagnosed. They said, you're gonna have surgery, you're gonna have radiation, you're gonna go through, a whole recovery process. And I said, great, when? Like, how soon can we do this? Fast forward, and now I'm not awesome at math, but I'm pretty sure it's been like 15, 16 years since the diagnosis. And when I go to the doctor, they're like, what the hell? Like, you were way over-treated. Like, I would have done this, but not that. I would have treated you 100% differently. And I'm like, well, shoot. Like, you can't take that one back, right? And so lesson number one for me is like, question. It's okay to get a second opinion. And I know this all sounds like very, like I've heard that before, but really, like, just because someone says something does not mean it to be true. And we can apply that to all aspects of our life, right? The second piece was after the surgery, after the radiation, then I was left with no thyroid hormones. Oops, sorry, microphone. And that's where the thyroid is. And, you know, it was like, okay, well, we don't know what kind of dosage of medication to give you. Like, let's just like pick something out and throw it at you. And I imagine maybe when you're going through hormone replacement therapy, it's a very similar process, right? Like, we don't know, let's be your guinea pig today. And they would say, okay, take this dose, and you gotta wait at least 6 weeks before you know if it's right or wrong. And I'm very in tune to my body, and I would know after a week and a half. I was like, not right, too much, too little, don't feel good. And I would tell the doctor, and they'd go, no, you can't know that fact. And I would say, bullshit, sorry, I hope that's okay to say in here. But it is wrong. It is wrong, and I need you to fix this. And when you push back just a little bit, they'd be like, oh, okay, well, let's try something else. And so, again, it's just like a little tweak in life that, you know, again, if you're somebody that grew up like not questioning authority, and, you know, at 42 years old, I was still scared of authority, you know, because it's just in you, right? But it's okay, because we're all just people at the end of the day. And so lesson number 2, like, listen to your body. If it doesn't feel right, say something.
Yeah, it's, you know, it is hard. It's getting used to, like, you know, and again, you know, you speak of it is when it comes to these differences in race and so forth. I can tell you, growing up black, we were just taught, don't question the doctors. Get in, get out. Yeah. You don't want them to think, like you said, think you're angry. Or, you know, or what, I was actually one of the people in the, you know, who said, angry black woman is the most common thing you hear, is you don't want to come off as angry. You don't want to, you know, to push that envelope, because, you know, then they'll think that you're, you know, you're problematic, and it goes in your chart and all these things. But we really have to start to advocate more for our care, and what would have taken you, 6 weeks, you know, to figure out something you knew in a week, right? So I think that we have to push back a lot against what, you know, medical professionals have said, which a lot of it isn't correct. Yeah. But also, you know, you mentioned the lack of inclusivity in research. Can you kind of delve into that a little bit more?
Yeah, so, you know, there just is, because there hasn't been a lot of research done on women for the reason that we talked about before, a lot of doctors don't know as much as they need to about women or people, trans people. And so there's a lot of onus, I think, that you all know very well, that it's almost like there has to be education by the patient at the same time as there is, you know, treatment by the doctor, right? And, you know, I think that, hold on, I'm just looking here, that, you know, if we talk about like pain management, and I know we've talked about the differences in pain management across races, but it's the same with gender. So men who are dealing with pain are brave and courageous and stoic, right? Where women are emotional, and maybe they are weak or have mental illnesses, right? And so there are just inequities that we just have to continue to push for and advocate for, to make sure that, you know, we're all getting what we need.
Yeah, but it doesn't stop me from being in like a state of rage about it quite a lot of the time.
Yeah.
And I can't help but think, like, again, having given birth, I'm in the throes of menopause, right? Like all of these different stages in my life. And I think to myself, if men, straight men, cis men, were going through half the things that women go through, right? Or folks with uteruses, right? Like on any given day, what a different approach it would be.
Yes.
Right? You grow up as a young woman and you are told, or, you know, a young girl, and you're like, you'll get your period when you get it.
Yeah.
So you just spend a good 2 years of your life hoping it doesn't come at a certain time, trying to be in the gym class, like doing all of these gymnastics, right? Around this thing that happens to everybody who has a uterus for the most part. And yet we're cool with that.
Right.
Imagine if something happened to the other percent of the population. We'd have a date. There'd be a
gone.
test. We'd know all the things.
Yep.
Right? So that
Yep.
you would not be caught out there off guard in a meeting. And right, none of that. But we don't do that for us. Right? And then again, you layer on the other pieces of it. Right? Like you think about just all of the various moments when you are at your most vulnerable, when you are making some of these choices, right? And so I am a very outspoken person. I pride myself on how extroverted I am. You will not cut me in the line. You will not, like, these are part of my core identity as a human being. And yet I shouldn't be in a position where when I'm in the mammogram thing at my most vulnerable, I gotta be having a conversation about whether or not you're treating me right, right? And those are the types of things that we see over and over again. And I feel like my role as someone who does sort of sit in that space and is more comfortable is to advocate for the people who don't. Right? So if I know that the experience of, someone who is trans, who is also now going to be in that same machine with me, is going to look really even worse, right, than what I'm experiencing, like, what can I be doing in my conversations to help, right, make it so that the next person who steps into that seat doesn't have to have the same question asked, right, or this advocate for themselves in the same way. But that burden bothers me. Right? And I feel like it's a burden that you often have to carry as a woman, as a trans person, as a Black person, right? And you just layer, and it weighs on you, right? It's a reason why you see the disparities in our health. That's not by accident, right? It's because we're walking through the earth with all of these extra burdens, all of these extra things that we're carrying. So, I don't know. Again, it makes me mad. So I needed a minute to have a little catharsis with y'all.
I'm
about
picturing
that.
right now if men had to get mammograms, like some sort of like laser from across the room, be like, boop, nope, you're good.
Listen,
right? No squish.
I am not like trying to man hate in any way, right? Y'all got stuff that y'all deal with. No one is trying to diminish that. But I do think, right, like we all just need to be much more mindful. And I think the medical profession as a whole, right, has a responsibility to keep up. Right? Like you would know, doctors talk about it all the time. They're in the business of like, they get recertified, they have to learn new things. We need to be making sure that the things that they're learning are actually matching up with the lives that the people that they're treating are living.
Yeah.
And I think one thing that's important to point out too is so much of the way the medical system is based around gender expectations and not so much on what is realistic. So when we speak of women's health, yes, it's titled as women's health, but
Absolutely.
there are trans men who have to experience, mammograms because, let's say that's where they are in their journey, or that's where they choose to stay in their journey, as well as, trans women. Like, right now I am growing breast tissue. I am on estrogen. I am growing breast tissue. I have those to look forward to. I am not excited about them being smashed between things. It's been described to me. There's something affirming and euphoric about having an experience that I get to share with, cishet women. But I'm not looking forward to that. I would love for them to be cared for more. I've worked really hard to get to that point. But also as a trans woman as well, like, we don't talk about in women's health, we don't talk about prostate exams because it's seen as a solely male thing. But there's, when we talk about, cancer screenings and things like that, the fact that doesn't get brought up enough, like the fact that, mammograms don't get brought up to me.
Right.
And that's a real concern because the whole idea of breast cancer is the more breast tissue you have, the higher chance you have of having something like that. So I would like to know. Thankfully, I have advocates like my spouse who is like, hey, you had it running in your family. She's on top of everything. Like, trust me, I am brain dead most of the time. She is on top of everything. I love her. Love you, honey. But like on the other way around is these are all like, until the world changes, we do have to acknowledge that when we speak of women's health, we're not just speaking of cishet women. We are speaking of trans men,
Absolutely.
and we're speaking of trans women who are in different parts of their journeys. And hopefully, on the other side of things that we're not talking about today, but cishet men, there are things that trans men and cishet men will go through that are the same. And that's not, and forgive me, that's not even getting into intersex people who have got to deal with a whole plethora of things that are combined everywhere, right? And that's where that intersectionality comes in.
And it shouldn't be that it's, a specialty moment, right? Like you shouldn't have to be, like you should have, I think, a baseline, right? Understanding in the medical profession when you
That's right.
walk through into a facility that someone has some understanding. Maybe they're not an expert, but they can get you started, right? Not you having, to your point, be the educator for all of these
Right.
moments.
Like, what if we just treated people like humans? Period.
It's like, you're a human, you have this thing, or
Right.
this thing, and so we are going to look at the conditions of this thing.
Right.
Yeah.
For sure.
So, and one thing I wanted to call out here is when we were bringing this panel together, and I love this about you because we always talk about allyship and advocates and so forth, or I like to say accomplice, is sometimes the people who you want to be your allies are the people who question, like, am I at the right person at the table, right? Should I be here or should this be a space for somebody else? And I know you and I, Angie, we had that conversation of, here I am, I'm a cis white woman, should I be on this panel? And, I think just to call it out, I think it's important to call out the fact that you may be a cis white female, but the experiences that you have, other women have. There may be experiences that trans women will have that you don't have, or black women will have, and we're speaking black women here, but any culture may have that you don't have. And this goes, I'm not directing this directly at you, this goes to everybody, is I learned this from a comedian, and I can't remember the comedian, so forgive me, but I love it, is we often will put somebody down and say, oh, that's first world problems. But that's wrong. It's, because we never put somebody down for having what we call third world joy. No matter what level of joy it comes from, it's joy and we celebrate it. When somebody has a problem, we should be looking at it because we should be able to say to ourselves, I'm having this problem. Is anybody else having this problem? Or this person's having this problem. Why am I not having this problem? And be able to study that and find out where we can advocate for those that don't have it. So that all being said, forgive me here, I'm lost my train of thought. So in gaining understanding of these things, I'd like to ask, what else can we do? Like, I'm sorry, brain fart there. If there was lessons we could learn from that, what would you say those lessons would be?
I think for me, for sure, just not assuming that my situation is the normative situation, right? And being able to ask questions in a way that help others, right? Who, to your point, may be in a different place in the continuum than me. So when I go, like, really trying to have a conversation with my doctor that is about, like, what is happening with me, so it's personalized, right? And I think that might be one way that we could sort of get to a place where we are helping to train our physicians, right, and others to not, like I go in and they weigh me, right? And they're like, this is the BMI, here's where you fall. And I'm like, is it possible that there's a different bucket for people who look like me? Like, is my bucket a little bit switched this way, right? Like, I think that there's room for us to question, right, some of these standards. And I think the more that we can go in and really be about, like, what is individually happening with me? Can we start our conversation, Dr. X, with that? I think would help, right, to just reframe the conversation a little bit. Like, they're still obviously going to benefit from research that looks at groups of people and all these things. So I'm not trying to be anti-scientific, but I do think we need that little bit of a paradigm shift because it's like, well, this is what's supposed to happen. And so if you don't fit into the what's supposed to happen, then something's off with you, right? And I'm like, or maybe I'm just built, like, is that a possibility? Can we have that discussion?
And I think that, like you said, that discussion part, and I think it's important to call out that science is about truth, like, and getting as close to that truth as possible. And, like you said, is sticking me in a wide bucket, you're not going to get as close to the truth as if you look at me as an individual, right? So I think you're right there, is to push, it's almost like pushing that science further as opposed to somebody telling you, oh, the science says this. Well, how far in the science did you go?
Yeah.
Because like you said, most of it was done, tests were done on men, right? And there's so many, like, and then what kind of men? It was done mostly on white men, and and white men who were not disabled, white men who were not this.
Right.
And so you have this such a finite, test base, if you will.
Yeah, I vividly remember giving birth to my daughter, and the midwife and the doula that we work with were both like, well, as part of your medical training, most folks who are OBGYNs don't have to sit with a woman from the time she goes into labor until she gives birth. Like, that's not part of the training. So they actually have never seen in the course of their training that arc for even one woman or one person giving birth, much less everybody, right? And the way you're treated during that process often is about, I gotta birth 6 of these babies, so I need you to be on a schedule, because on average, we've seen that people do it in 8 hours. But you might be 24 hours, or you might need 10 hours, or you might need 2, but you've never actually seen that whole arc as part of the course of your normal training. To just sit and be with someone who's going through this process that you are going to help facilitate over and over and over and over again over the course of a career. Like, that was mind-boggling to me.
Yeah, I didn't know that. That's a mind blower.
Right? Like, and so it's little things like that, right? Where you could ask, you're like, have you ever treated somebody who has X, Y, or Z?
I think it's actually a really good point, as you both were talking, and the stories that you shared before we came up here, is that finding somebody that feels like a partner to you, and you can look them in the eyes and say, this is a plan that we want to have together. And I love that you found a doctor that's addressing you as a whole person, your mind, your body, et cetera. But instead of someone who's like, statistics say this, so you're here, check. And instead it's like, well, no, I want to go here. I want my level to be this. My goal is that. I'm concerned about this. How can we get there in a way that feels right to me is really important.
So it's kind of, again, like using those facts to support the conversation, not to define them.
Yeah.
I'm sure there's going to be like 85 doctors watching this. They're going to be like, these people on this panel,
what are they?
Well, to have 7 seats.
Good.
Call us.
We got things to say.
Yeah.
Now, and I do know we're running out of time here, but one thing, Angie, is you explained to us in our conversations about how you approach things with your family, and I would love for you to share a little bit about that.
Yeah, real quickly, I know, Erica, you have something good to share here too, but and actually, Sasan's daughter brought this up today, so I was like, okay, good, we're doing this. But, there's so many societal expectations on gender, right? Everything from your body size, your body type, who you date, et cetera. And so, I think we see this a lot with older generations, like, do you have a girlfriend? And I have 3 sons. I'm a mother of 3 sons. And so, people are always asking these questions. Do you have a girlfriend? And I always pop in and be like, or a boyfriend. My kids, my oldest one's 11, so hopefully they have none of that going on, right? But, I'm laying the groundwork here. But, even beyond that, and it was great to hear Ariana reinforce that, but even beyond that, just the body types of my 3 kids are so incredibly different. My oldest son is like a zipper. He's like tall, skinny, My other guy is stocky. Looks like, he can lift some weights some days, and the other guy's a baby, so he's just chubby and crazy, right? But there are comments constantly, even about my 11-year-old son and his body. And I'm like, these are the things that stick with you from the time you're a teeny little kid to forever. I'm 5'9", and I've always been told I was like an Amazon woman since the time I was 4 years old. And so I have like definite dysmorphia. And so just, again, it's like, find a healthcare professional or somebody who treats you from the inside, right? Not as your body, and treats your mind with it too. And we can all start by making those changes in the way that we address each other. Why not just not talk about, oh, you lost weight, and instead say, hey, love that sweater, right?
It's a
like, let's just not.
Right.
Yeah.
Erica, you had something to share too?
I was like, I don't think I need to follow that. Thank you for having us.
Well, again, I would like to thank you both of you very much for having this conversation, and it's been a joy talking to both of you, really just acknowledging the disparities, acknowledging the privileges, and acknowledging how we can move forward into better lives for all of us, right? And I'm really honored to be, to be able to partner with the Women's Network and be able to partner with the African Ancestry Network and feel like I'm welcome into those spaces, first of all, and to find that we have that commonality. So again, thank you very much. And one thing I want to say to everyone is, remember that we're one group of voices, right? We're one group of voices, and when one struggles, we all do. And that's all. Thank you.
Thank you, Dee.